So, mast cells may be implicated in the pathology associated with autoimmune inflammatory disorders of the joints. They have been shown to be involved in the recruitment of inflammatory cells to the joints, like in rheumatoid arthritis, in skin, in bullous pemphigoid. And this activity is dependent on antibodies and complement components. In anaphylaxis, the body-wide degranulation of mast cells lead to vasodilation and, if severe, symptoms of life-threatening shock. Histamine is the uh, vasodilator that is released during anaphylaxis. Now, um, a mast cell is a type of white blood cell. Specifically, it is a type of granulocyte derived from the myeloid stem cell that is a part of the immune and neuroimmune systems and contain many granules rich in histamine and heparin. Although best known for their role in allergy and anaphylaxis, mast cells play an important protective role as well, being intimately involved in wound healing, angiogenesis, immune tolerance, defense against pathogens, and blood-brain barrier function. The mast cells are very similar in both appearance and function to basophils. Although mast cells were once thought to be tissue-resistant basophils, it has been shown that they do have different hematopoietic lineages and cannot and uh, are not the same cells. Mast cells are very similar to basophil granulocytes, which is a class of white blood cells. Both are granulated cells that contain histamine and heparin. Their nuclei differ in that the basophil has a lobated nucleus and the mast cell has a round nucleus. The Fc region of immunoglobulin becomes bound to mast cells and basophils, and when IgE paratopes bind to an antigen, it causes the cells to release histamine and other inflammatory cells. Again, the Fc region of IgE, remember that Fc region is a region in the immunoglobulin E that is Fc because it's the fragment crystallizable region. And this is the tail region of the antibody that interacts with cell surface receptors called Fc receptors and some proteins of the complement system. This property allows antibodies to activate the immune system. So this uh, this fragment crystallizable region, Fc region of immunoglobulin E, becomes bound to mast cells and basophils, and when IgE paratopes bind to an antigen, it causes the cells to release histamine and other inflammatory mediators. These similarities have led many to speculate that mast cells and basophils that have homed in on tissues. Furthermore, they share a common precursor in bone marrow. So, basophils and mast cells mature differently. Basophils leave the bone marrow already mature, whereas mast cells circulate in an immature form, only maturing once in a tissue site. The site an immature mast cell settles in probably determines its precise characteristics. The first, okay, so mast cells are divided into two subtypes: connective tissue type mast cells and mucosal mast cells. The activities are dependent on T cells. Mast cells are present in most tissues, characteristically surrounding blood vessels and nerves, and are especially prominent near boundaries between the outside world and the internal milieu, milieu such as the skin, mucosa of the lungs, digestive tract, mouth, conjunctiva, and nose. Mast cells play a key role in the anti-inflammatory process. When activated, a mast cell can either selectively release or rapidly release mediators or compounds that induce inflammation. When it's selectively releasing, it's called a piecemeal degranulation, and when it's releasing rapidly, it is an anaphylactic degranulation. And these compounds or mediators that induce inflammation from storage granules into the local microenvironment. These mediators are going to be released selectively by mast cells. Now, mast cells can be stimulated to degranulate by allergens through cross-linking with IgE receptors. Physical injury through pattern recognition receptors for damage associated molecular patterns. This is DAMPs, or PAMPs, which is pathogen associated molecular patterns. And this is a microbial pathogen through pattern recognition receptors, and various compounds through their associated G protein couple receptors. Again, or various compounds through their associated G protein couple receptors, or ligand gated ion channels. Complement proteins can activate membrane receptors on mast cells to exert various functions as well. So, mast cells express a high affinity receptor in the Fc region of the IgE, which is the least abundant member of the antibodies. So again, mast cells express a high affinity receptor for the Fc region of IgE. Remember that Fc stands for fragment crystallizable region. So mast cells have high affinity um, for this fragment crystallizable region. Mast cells have a high affinity for this fragment crystallizable region of IgE. And in this Fc region of IgE, which is the least abundant member of the antibodies, IgE, so this Fc receptor is such high affinity that binding of IgE molecules is in essence irreversible. Okay, because the Fc, which is a fragmentable crystallizable region, is so has a high affinity to mast cells that is basically an irreversible bond that they make. So this receptor is such a high affinity that binding of IgE molecules is in essence irreversible. As a result, mast cells coated with IgE, which is produced by plasma cells, um, as a result, mast cells are coated with IgE, which is produced by plasma cells. um, plasma cells because the antibody producing cell. Plasma cells are the antibody producing cells of the immune system. So IgE molecules, like all antibodies, are specific to one particular antigen. This meaning, if you have an antigen like pollen, for example, you're breathing it, this pollen is this IgE is specific to that pollen. So that that is the way that the IgE will be stimulated. Okay. In allergic reactions, mast cells remain inactive until an allergen binds to IgE already coated upon the cell. Other membrane activation events can either prime mast cells for subsequent degranulation. Again, other membrane activation events can either prime mast cells for subsequent degranulation or act in synergy with signal transduction receptors. In general, allergens are proteins or polysaccharides. So this polysaccharide, like pollen, is an allergen. This allergen will stimulate uh, the two IgEs, these IgE molecules, which are attached to the mast cells. And once it attaches, these IgEs will stimulate the mast cells to release its chemicals that are going to do the function of the mast cell. So in allergic reactions, mast cells remain inactive until an allergen binds to IgE already coated up on the cell. Other membrane activator events can either prime mast cells for subsequent degranulation or act in synergy with receptors to do signal transduction. In general, allergens are proteins and polysaccharides. The allergen binds to the antigen and binding sites, which are situated on the variable regions of IgE molecules bound to the mast cell surface. It appears that binding of two or more IgE molecules is required to activate the mast cells. The clustering of the intracellular domains of the cell-bound Fc receptors, which are associated with the cross-linkage of IgE molecules, causes a complex sequence of reactions inside the mast cell that leads it to activation. Although this reaction is most well understood in terms of allergy, it appears to have evolved as a defense system against parasites and bacteria. So the mediators of mast cells, a unique stimulus specific set of mast cells mediators is released throughout the granulation following the activation of cell surface receptors on mast cells. Examples of mediators that are released into the extracellular environment during mast cell degranulation include, and all these are mediators, many of them are mediators for inflammation, etc. So some examples of these mediators that are released into the extracellular environment during mast cell degranulation include, so this means that all these mediators come out of the mast cells. There will be histamine, proteoglycans, mainly heparin, which is an active anticonvulsant, some chondroitin sulfate proteoglycans, ATP, lysosomal enzymes like beta hexosaminidase, beta glucuronidase, and aryl sulfatases. So, lipid mediators or eicosanoids like thromboxane, prostaglandin D2, leukotriene C4, And remember, that is why Montelocast works more, because Montelocast will decrease the granulation of these leukotrienes to avoid um, allergies, decrease allergies. Also, platelet activating factors. It will release cytokines like tumor necrotizing factor A, basic fibroblast growth factor, interleukin 4, stem cell factors, and serine proteases, and histamine. Very important. Probably one of the most important in this case will be histamine, because, as you know, histamine is an organic nitrogenous compound involved in local immune responses as well as regulating physiological function in the gut and acting as a neurotransmitter for brain, spinal cord, and uterus. So histamine is a very important um, substance or a very important molecule. Histamine is involved in inflammatory response. So, okay, histamine dilates postcapillary venules, activates endothelium, and increases blood vessel permeability. This leads to local edema, warmth, redness, and the attraction of other inflammatory cells to the site of release. So histamine also is a mediator, to attract inflammatory cells. It also depolarizes nerve endings, leading to itching and pain. Cutaneous signs of histamine release are the flare and wheal reaction. Flare and wheal reaction, which is a wheal is a cutaneous condition uh, that affects the integumentary system, the organ system that encloses the body and includes skin, hair, nails, and related muscle and glands. The major function of this system is as a barrier against the external environment. So, flare and wheal reaction is a cutaneous sign of histamine release. The bump and redness The bump and redness immediately following a mosquito bite is a good example of this reaction, which occurs seconds after showing of the mast cell by an antigen. The other physiologic activities of mast cells are much less understood. Several lines of evidence suggest that there is a role in innate immunity. Um, so, okay. Um, the granulation. Oh, okay. We'll skip mast. We'll skip the granulation. We're gonna go into mast cell activator disorders, and these are a spectrum of immune disorders that are unrelated to pathogenic infection and involve similar symptoms that arise from secreted mast cells intermediates, but differ slightly in their pathophysiology, their treatment approach, and their distinguishing symptoms. The classification of mast cells. Okay, never mind. So, allergies. Allergies are mediated through IgE signaling, which triggers mast cell degranulation. Many forms of cutaneous and mucosal allergy are mediated in large part by mast cells. They play a central role in asthma, eczema, itch from various causes, in allergic rhinitis, and allergic conjunctivitis. Antihistamine drugs act by blocking histamine action on nerve endings. Chromoglycate-based drugs block a calcium channel essential for mast cell degranulation. stabilizing the cell and preventing release of histamine and related mediators. And the leukotriene antagonists like montelukast and zafirlukast block the action of leukotriene mediators and are being used increasingly in allergic diseases. Calcium triggers the secretion of histamine from mast cells after previous exposure of sodium fluoride. This secretory process can be divided into fluoride activation step and calcium activation induced secretory step. It was observed that the fluoride activation step is accompanied by an elevation of the cyclic adenosine monophosphate camp levels within the cell. Again, the secretory process can be divided into fluoride activation step and the calcium induced secretory step. It was observed that the fluoride activation step is accompanied by an elevation of cyclic adenosine monophosphate levels within cells. The attained high levels of cyclic AMP persist during histamine release. It was further found that catecholamines do not markedly alter the fluoride-induced histamine release. Again, the attained high levels of cyclic AMP persists during histamine release. It was further found that catecholamines do not. Okay, we're gonna stop right there. We're gonna continue reading. Okay, so anaphylaxis. In anaphylaxis, a severe systemic reaction to allergens such as drugs, nuts, bee stings, etc. Um, there is a degranulation, there's a body-wide degranulation of mast cells that lead to vasodilation, and if severe, uh, the symptoms can be life-threatening. Uh, can be the symptoms of a life-threatening shock. Histamine is a vasodilatory substance that is released during anaphylaxis. Now, histamine has a lot of good things that it does, but if there is a release of histamine uh, that is systemic, there can be a lot of issues, a lot of problems. Now, um, the reason why we started reading all this is because we wanted to know about autoimmunity that is found in many diseases, in many syndromes, in mucosal lesions, immunologic diseases. Now, these conditions, these conditions are related to autoimmune or hyperimmune reactions to known or undetermined antigenic stimuli. Clinical manifestations include vesicles or bullae, ulcers, erythema, and white patches. There will be different forms, different things that we're going to see. Aphthous ulcers, Aphthous ulcers are recurrent painful ulcers that are not preceded by vesicles. Okay, so they are not preceded by vesicles. These are recurrent painful ulcers. They are of unknown cause, but probably related to a focal immune defect. They appear on wet, non-vermilion, non-keratinized oral mucosa, i.e., not hard palate or hard gingiva. So there's three clinical types, which is a minor, major, and herpetiform. May be seen in association with some systemic diseases. That is um, aphthous ulcers. Now, there is different types of aphthous ulcers. If they're minor, you'll see one to several painful oval ulcers, less than zero point 0.5 centimeters. And this is the most common type, and they the duration is 7 to 10 days. There is a major aphthous ulcer in which there is up to 10 deep crateriform ulcer of more than zero point 0.5 centimeters. And there's a herpetiform ulcer in which um, there is recurrent crops of minor after painful. They take 1 to 2 weeks to heal. They may be found on any mucosal surface, same case as other after that are non-viral, not viral. So the major after ulcer is the most painful, and it can be up to 10 deep crateriform ulcers that are bigger than zero point 0.5 centimeters. They're very painful and may be debilitating. They may take several weeks to heal. Um, so this is about after ulcers. Also, there is systemic diseases in which you will see after ulcers, and these are going to be uh, Crohn's disease. In Crohn's disease, well, we can see Crohn's disease, Behçet's syndrome, celiac sprue, and AIDS. Each of them have a systemic condition, and then we'll see the oral lesion characteristics. In Crohn's disease is a systemic condition in which granulomatous inflammation, there is a granulomatous inflammation of the GI tract. Okay, so Crohn's disease is a systemic condition in which there is a granulomatous inflammation of the GI tract. Okay, and in Crohn's disease, you will see a minor apta. Okay, next disease is or condition or syndrome is Behçet's syndrome. Behçet's syndrome is immune dysfunction featuring vasculitis. Okay, you will see also minor apta. Celiac sprue is a gluten-sensitive enteropathy. There's minor apta, and AIDS is an immunodeficiency. In this one, you will see major apta. Okay. Um, so now let's talk about Behçet's syndrome. Behçet's syndrome is a multi-system disease that is believed to represent immune dysfunction in which vasculitis is a prominent feature. Okay? Behçet's syndrome is going to be seen in BOOG. Behçet is found in oral, oculo, and genital. BOOG, Behçet, BOOG. So Behçet, again, multi-system disease believed to represent immune dysfunction in which vasculitis is a prominent feature. Vasculitis. Um, you will find oral and genital aphthous type ulcers conjunctivitis, uveitis, which is the inflammation of the layers of the eye, arthritis, headaches, and other central nervous system manifestations. It is treated with corticosteroids and other immunosuppressive drugs, Behçet's corticosteroids and other immunosuppressive drugs. Okay, next syndrome or next condition is erythema multiforme. In erythema multiforme, you will find okay, you will find that erythema multiforme is a self-limiting hypersensitivity reaction that affects skin or mucosa or both. Again, erythema multiforme is a self-limiting hypersensitivity reaction self-limiting hypersensitivity reaction that affects skin or mucosa or both. Minor form associated with secondary herpes, simplex hypersensitivity. In the major form, Stevens-Johnson's syndrome, often triggered by drugs. So this is erythema. Okay, let me see. We need to see a little bit about um, erythema. Erythema, we know what it is, but we need to know more details. Erythema is redness of the skin or mucous membrane caused by hyperemia, which is an increased blood flow in superficial capillaries. It occurs with any skin injury, infection, or inflammation. Examples of erythema not associated with pathology include nervous blushes. So, it can be caused by infection, massage, electrical treatment, acne medication, allergies, exercise, solar radiation, photosensitization, cutaneous radiation syndrome, mercury toxicity, um, blister agents, niacin administration, or waxing and tweezing of hairs, any of which can cause the capillaries to dilate, resulting in redness. Erythema is a common side effect of radiotherapy treatment due to patient exposure to ionizing radiation. Erythema disappears on finger pressure, while purpura or bleeding in the skin and pigmentation do not. Why? Because when you press on the skin, you make the blood go away. There is no temperature elevation unless it is associated with the dilation of arteries in the deeper layer of the skin. There's many types of erythema. Erythema multiforme is what we're interested on, and is a skin condition of unknown cause. It is a type of erythema possibly mediated by the position of autoimmune complexes, mostly IgM, in the superficial microvasculature of the skin and oral mucous membrane that usually follows an infection or drug exposure. It is an uncommon disorder with peak incidence in the second and third decades of life. The disorders have various forms of presentation, which is its name reflects multiform. Target lesions are a typical manifestation. The two types, one mild to moderate and one severe, are recognized. Okay, the condition varies from mild self-limiting rash to a severe life-threatening form that also involves mucous membranes. Um, there's three different types of erythema. The first one is erythema multiforme minor, which typically targets or raised um, edematous papules are distributed acrally, acrally, acrally. Um, acrally means peripheral body parts such as toes, fingers. So this is the erythema minor, targets of raised edematous papules distributed acrally, and erythema multiforme major, which targets typical targets or raised edematous papules distributed acrally with involvement of one or more mucous membranes. Epidermal detachment involves less than 10% of total body surface. Okay? Now, the next one will be the Stevens-Johnson syndrome, which is a widespread blisters predominant on the trunk and face, presenting with erythematous or pruritic macules and one or more mucous membrane erosions. Epidermal detachment is less than 10% for Stevens-Johnson syndrome, okay, and 30% or more for toxic epidermal necrolysis. Now, um, again, erythema multiforme is a self-limiting hypersensitivity reaction that affects skin or mucosa or both. Its minor form is associated with secondary herpes, simplex sensitivity, and its major form is Stevens-Johnson syndrome, which is often triggered by drugs. Okay, so the mild form usually presents with mildly itching, but itching can be very severe. Pink red dot blotches, symmetrically starting arranged and starting on the extremities. It often takes on the classical target lesion appearance with a pink red ring around the pale center. Individuals with persistent chronic erythema multiforme will often have lesion from an injury site or a minor scratch or abrasion within a week. Irritation or even pressure from clothing will cause the erythema sore to continue to expand along its margins for weeks and months, long after the original sore at the center heals. Causes: infections like bacterial infections, um, vaccinations. Oh, okay, okay. So infections can be bacterial, fungal, parasitic, viral, drug reactions, radiotherapy, cold, sunlight, collagen diseases, vasculitis, non-Hodgkin's lymphoma, leuke- leukemia, multiple myeloma, myeloid metaplasia, polycythemia. But anyway, there is a list of human leukocyte antigens. Well, no, never mind. Many etiologic factors have been reported to cause erythema multiforme. So, simplex virus suppression and even prophylaxis with acyclovir has been shown to prevent recurrent erythema multiforme eruption. Erythema multiforme minor is regarded as being triggered by um, herpes simplex virus in almost all cases. A herpetic etiology also accounts for 55% of the cases of uh, erythema multiforme major. Among other infections, mycoplasma infections appear to be a common cause. Erythema multiforme is frequently self-limiting and requires no treatment. The appropriateness of glucocorticoid therapy can be uncertain because it is difficult to determine if the course will be resolving one. So that is erythema and Steven Johnson's and the two types of erythema. Remember that Steven Johnson's will have a more severe form, and it's a more severe form and is often triggered by drugs. Um, anyway, now we're gonna see about Wagner's granulomatosis, granulomatosis, Wagner's granulomatosis. So Wagner's granulomatosis is um, is a long-term systemic disorder that involves both granulomatosis and polyangiitis. Polyangiitis is um, inflammation of multiple blood vessels or lymph vessels. That's polyangiitis. So, Wagner's granulomatosis. When you see a Wagner's granulomatosis um, case in a microscope, you will see you will have a the characteristics of the granulomatosis with polyangiitis. You will see vasculitis and granulomas with multinucleated giant cells. Multinucleated giant cells. So, granulomatosis with polyangiitis, formerly known as Wagner's granulomatosis, is a long term systemic disorder that involves both granulomatosis and polyangiitis. It is a form of vasculitis, which is an inflammation of the blood vessels that affects small and medium sized vessels in many organs, but most commonly affects the upper respiratory tract and the kidneys. Remember that this granulomatosis is an inflammation found. It's a granuloma, which is a inflammation found in many diseases. It is a collection of immune cells known as macrophages. So that is a granuloma. A granuloma is a granulomatosis. It's a collection of macrophages. Granulomas form when the immune system attempts to wall off substances it perceives as a foreign but unable to eliminate. Such substances include infectious organisms, including bacteria um, and fungi, as well as other materials such as keratin and suture fragments. So, when you see a granuloma on an extraction site uh, surrounding a foreign body, that's what you see. You just see a lot of inflammation cells, macrophages, just surrounding it. So in pathology, it is a collection, organized collection of macrophages. In medical practice, doctors occasionally use the term granuloma to mean a small nodule, since a small nodule can represent anything from harmless nevus to a malignant tumor. This usage of term is not very specific. Examples of inaccurate use. Okay, anyway, so um, there, the going back to Wegener's granulomatosis, the typical signs of Wegener's granulomatosis are going to be nosebleeds, stuffy nose, and crustiness of nasal secretions, and inflammation of the uveal layer of the eye is very similar to Behçet's syndrome, which there is a inflammation of the layers of the eye, uveal layers of the eye. There is damage to the heart, lungs, and kidneys, and it can be fatal. The cause of granulomatosis with polyangiitis or Wegener's granulomatosis is unknown. Genetics play a role in Wegener's granulomatosis or granulomatosis with polyangiitis. And Wegener's granulomatosis is very important because it didn't have the polyangiitis before, and the fact that it is now granulomatosis and polyangiitis is very important because now it tells you that it's not only granulomas, but also you're gonna be finding inflammation of blood vessels and lymph nodes. So um, Wegener's granulomatosis, it's a destructive granulomatous lesions with necrotizing vasculitis of unknown cause. Affects upper respiratory tract, lungs, and kidneys. Um, kidney, respiratory tract, lungs, and kidneys. The diagnosis is based on biopsy and demonstration of anti-neutrophil cytoplasmatic antibodies. Again, its diagnosis is based on a biopsy and demonstration of anti-neutrophil cytoplasmatic antibody. So anti-neutrophil cytoplasmatic antibody. The treatment is with cyclophosphamide and corticosteroids or rituximab. Prognosis is good. So granulomatosis and Wegener's granulomatosis with polyangiitis is a part of large group of vasculitic syndromes called the systemic vasculitides or necrotizing vasculopathies, all of which feature an autoimmune attack by an abnormal type of circulating antibody termed ANCAs, which is an anti-neutrophil cytoplasmatic antibody. We were just reading that. Anti-neutrophil cytoplasmatic antibody, which is ANCAs. Anti-neutrophil cytoplasmatic antibody. So these anti let me see anti-neutrophil cytoplasmatic antibodies. These are a group of antibodies mainly of the IgG type against antigens in the cytoplasm of neutrophil granulocytes and monocytes. They are detected as a blood test in a number of autoimmune disorders, but are particularly associated with. Okay, so although Wegener's granulomatosis or granulomatosis with polyangiitis is affects small and medium-sized vessels. It is uh, classified as one of the small vessel vasculitides in the Chapel Hill system. Now, the Chapel Hill system is a consensus that went from 1994 to 2012 and are um, conferences which addressed the need to standardize classification of systemic vascularities. So, Behçet's disease, Behçet's disease is included there. Lupus, rheumatoid arthritis, and vasculitis associated with hepatitis C and hepatitis B, virus-associated vasculitis. Anyway, so that was just something to say about that. But um, okay, so the signs and symptoms of a Wegener's granulomatosis or granulomatosis with polyangiitis. Um, Initial signs are extremely variable, and diagnosis can be severely delayed due to non-specific nature of symptoms. In general, rhinitis is the first sign for most people. Involvement of the upper respiratory tract, such as the nose and sinuses, is seen in nearly all people with Wegener's granulomatosis. Typical signs and symptoms of nose or sinus involvement include crusting around the nose, stuffiness, nosebleeds, runny nose, and saddle nose deformity due to a perforate septum. Scleritis and conjunctivitis are the most common ocular signs of Wegener's granulomatosis. Involvement of the eyes is common and occurs in slightly more than half of people with the disease. Now, kidney. In people with Wegener's granulomatosis, there is a rapid progressive glomerulonephritis leading to chronic kidney failure. There's upper airway, eye, and ear disease. The ears are conductive hearing loss due to auditory tube dysfunction. Oral cavity, strawberry gingivitis, underlying bone destruction with loosening of teeth, non-specific ulcerations throughout oral mucosa. Trachea, you will find subglottal stenosis, lungs, pulmonary nodules, like that are referred as coin lesions. All these are Wegener's, okay, coin lesions, and infiltrates, cavitary lesions, arthritis, skin, nervous system, heart, gastrointestinal tract, and brain are going to be rarely affected. But um, the pathophysiology, the classic microscopic features of Wegener's granulomatosis or granulomatosis with um, polyangiitis um, include inflammation of blood vessels associated with poorly formed granulomas, necrosis in many giant cells. Bacterial colonization of staph aureus has been hypothesized as an initiating factor of an autoimmunity seen in people with granulomatosis. Several genes involved in the immune system. Um, anyway, It is widely presumed that anti-neutrophil system cytoplasmatic antibodies are responsible for the inflammation in Wegener's granulomatosis. So remember ANCAs, anti-neutrophil cytoplasmatic antibodies. Granulomatosis with polyangiitis or Wegener's granulomatosis is usually suspected only when the person has had unexplained symptoms for a long time. Determination of the ANCAs or anti-neutrophil and cytoplasmatic antibodies can aid in the diagnosis, but is not conclusive, and negative ANCAs are not sufficient to reject the diagnosis. More than 90% of people who have Wegener's granulomatosis or granulomatosis with polyangiitis test positive for ANCAs. Cytoplasmatic staining that react with the enzyme protein 3 in neutrophils are associated with granulomatosis with polyangiitis. Okay, so Wegener's granulomatosis, ANCAs, anti-neutrophil cytoplasmatic antibodies, treatment with cyclophosphamide and corticosteroids. Prognosis is good. Okay. Now we're gonna see now. Still need to see midline granuloma, lichen planus, lupus, and pemphigus. We're gonna finish that in the next video.